Good morning and welcome to the American Society for Microbiology's annual meeting, Microbe 2016, from Boston, Massachusetts. My name is Aliyah Khan and I'm the media manager here at ASM. This press conference today will focus on a phase 2 clinical trial that demonstrates that a new type of treatment for genital herpes, an immunotherapy called Gen-003. This therapy may reduce the activity of the virus and the number of days with recurrent herpes. I would like to introduce Dr. Kenneth Fife, investigator and professor of medicine at Indiana University, who will speak about his research. Thank you for being here today, Dr. Fife, and I'm going to hand it over to you.
Thank you. So I want to provide a brief summary of the study and then answer any questions if there are any regarding the study. So genital herpes is an important clinical disease. It affects approximately 15% of the adult population in the United States and more in minority populations. It's also a worldwide epidemic. It's the most common cause of genital ulcer disease throughout the world and is, in that regard, an important cofactor in transmission of HIV. So for many reasons, it's an important clinical disease that still has not been fully managed by current therapy. Although antiviral drugs that are currently available do a reasonable job of controlling symptoms, they still do not control the disease completely. They do not completely eliminate viral shedding from the genital skin in between outbreaks, which is a common time that the virus is transmitted. And suppression with antiviral drugs has been shown not to affect the propensity of herpes to promote the transmission of HIV in individuals at risk. For that reason, improved therapies for genital herpes are needed, and this study is an example of an attempt to try to improve on the current therapeutic management of herpes. Gen-003 is a novel therapeutic vaccine that was developed using techniques to identify the most important antigens for mounting an appropriate immune response to better control the virus once someone is already infected with the virus. This is in contrast to a prophylactic vaccine that takes people who are not infected with the virus and provides them with immunity to prevent them from becoming infected in the first place. The concept of a therapeutic vaccine, while interesting and very much a target of vaccine research, has really never been proven to work in a human disease. Our study was a study that took 2 different doses of the vaccine Gen-003 in combination with 3 different doses of a novel adjuvant called Matrix M to try to find the optimal combination of antigen and adjuvant to optimize the immune response of the subject and better control the viral shedding and symptoms. The 2 doses of the vaccine that were chosen were 30 and 60 micrograms of the vaccine protein, and the 3 doses of the adjuvant were 25, 50, and 75 micrograms of adjuvant. Subjects who had a history of 2 to 9 outbreaks of genital herpes per year were recruited for the study, and they were randomized to receive one of 6 combinations of vaccine and adjuvant or a placebo. And then they received 3 immunizations at 3-week intervals, and then were followed prospectively following the vaccination. To measure the response to the vaccine, we looked at viral shedding from genital skin. This is measured by doing daily genital skin swabs, where the subject takes a swab and swabs the genital area in a standardized fashion. Those swabs are then tested by polymerase chain reaction for HSV DNA, and this is a measure of viral activity. Most people who are infected with HSV2 will shed virus on the genital skin somewhere between 5 and 15% of days that they're sampled. Subjects underwent one of these episodes of skin swabbing before they received the vaccine, and then immediately after receiving the vaccine, and at approximately 6 and 12 months after receiving the vaccine. And this was the primary marker of the studies of the vaccine's activity was the effect on viral shedding. The over 300 subjects were enrolled in the study and followed for 1 year. The results of the study showed that the vaccine reduced viral shedding on genital skin by approximately 60%, with some variation based on dose of the vaccine and adjuvant. And so the range was actually from about 15% to about 60% reduction in viral shedding. This shedding change was seen immediately after the vaccination period and remained relatively constant at 6 and 12 months, especially at the higher doses of the vaccine. We also measured genital lesions formation as a secondary endpoint, and genital lesion formation was also reduced by approximately 50%, and again with a durability out to 1 year. Adverse events were also monitored at the time of immunization, and the vaccine was relatively well tolerated, with some adverse events being seen in most of the vaccine recipients, mostly local reactions such as soreness of the arm, swelling and redness of the arm in the first few days after the vaccination. Systemic side effects such as fever were less common, and there was no clear effect on repeated doses. In other words, the second and third doses were no less well tolerated than the first dose. In fact, they were somewhat better tolerated overall. So we saw no cumulative toxicity of the vaccine, and only 2 subjects discontinued the study as a result of adverse events. The FDA also required monitoring of adverse events of special interest, mostly autoimmune type phenomena, and none of these were seen. There were no serious adverse events seen in the study. In summary, the Gen 003 vaccine demonstrated a significant reduction in viral shedding and in genital lesion formation. The vaccine was well tolerated, and the responses to the vaccine in terms of negative events were roughly what would be expected from this type of vaccine. The combinations, the higher combinations of 60 micrograms of vaccine protein and 50 or 75 micrograms of adjuvant appeared to be the most effective and have the most durable effect, and will probably be the doses that will be further studied. Further studies will be done looking at longer-term effects of the vaccine, as well as potentially combinations with antiviral drugs. And then at some point in the future, perhaps this vaccine may be studied as well as a prophylactic vaccine, since it has such a strong activity in the therapeutic sense. So I think I'm available for questions at this point.
Good morning. Michael Smith, MedPage Today. A couple of quick questions. I may have misheard. You said the vaccine reduced viral shedding by 60%, and then you said actually it was a range, and I heard it as 15%, 15 to 60.
Right. The lowest doses were less effective, and they showed a lower efficacy. But at the higher doses, the 60% at the 2 highest doses was the suppression of viral shedding.
And in both of those doses, was it dose dependent, or did the top 2 doses roughly the same?
The top 2 doses were very similar in the viral shedding reduction. Yeah.
All right, and then the other question, again, a sort of technical question. 2 people stopped therapy because of adverse events. What were those? You said there were no serious adverse events.
There were no serious adverse events. Let me try to find this here. I think they were all local adverse events, pain at the injection site.
And so they would stop in the middle of the process. They wouldn't get the second or third shots, that sort of thing.
Correct, yeah.
So there was nothing systemic that they said, oh my Lord, I can't
Right,
deal with this.
systemic side effects are relatively infrequent, and this were not the cause of discontinuation.
Can you speculate on the effect of such a vaccine, if it was rolled out, on this 15% of the population that has genital herpes? What would the impact of an effective vaccine, of this type of therapeutic vaccine, be on that prevalence?
Well, it would allow them to reduce viral shedding and lesion formation for at least up to a year without taking a medication every day. In order to get this kind of effect from an antiviral drug, you would need to take the medication every day, which is something that many patients don't like to do. So that this would allow them to control their symptoms in a manner that's comparable to antiviral drugs without having to take a medication every day. And then, as I said, the other possibility is combining this with antiviral drugs to provide an even better overall response to control the disease.
Okay, that's an aspect of what I was asking, I think. So that's the individual benefit. I'm asking, but what about the population benefit? Does reducing shedding and reducing lesions prevent transmission? And if so, what would the impact of a vaccine be on prevalence in the population?
Right. So reducing shedding does reduce transmission. That has been shown with antiviral drug treatment. And so widespread use of the vaccine potentially could have an impact on transmission. You'd have to find somebody that can do the mathematical modeling to predict exactly what kind of an impact that would have. That's outside my area of expertise, but certainly reduction in shedding does reduce transmission, and so widespread use of this vaccine among people who are infected would potentially reduce transmission in the population overall.
Super, thank you.
Thank you for your questions. For those of you who are watching, if you have any questions, please feel free to email us at communications@asmusa.org, and we'll make sure we connect you with Dr. Fife. Thank you so much for joining us today, and goodbye from Boston.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shower.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an R scan. So the HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right? Remember, this building is basically a second building inside the main building.